Hello, and welcome back to Master Clinicians podcast series. My name is Dr. Frank Illuzzi. I am the Senior Vice President of Quality and Medical Education at CityMD, and I am sitting here with my dear friend and colleague, Dr. David Cohen, who is the co-founder of Teleradiology Associates and currently the Chief Medical Officer of Experity Radiology, which is the largest teleradiology partner in the urgent care sphere. And I'm welcoming back for the second part of our series in going through interesting x-rays as presented to the urgent care arena. And today we're going to be going over long bone injuries. And again, David, thank you for coming back and sharing your expertise with us. And I look forward to going through the films that you're going to go through on long bone injuries.
Awesome. Well, it's great to be back. Thank you for inviting me for a second round. I tried to bring some tougher cases today since it was hard to stump you last time. But as you said, we're going to be focusing on long bones, and hopefully I can bring some interesting cases and some teaching points for your listeners.
Well, fantastic. So without further ado, why don't we get into the cases and just have a little discussion on each of them. And similar to the last time, if you could go through what your approach is to each of the different, types of films, basically what is your methodology so this way you don't miss anything?
Absolutely, yes. And as we talked about before, it's kind of my favorite saying, it's simple, but it's not easy. These are x-rays. Most of the time, the diagnoses are pretty easy things that we're all familiar with, but when you're doing it over and over again and people are busy, it's not necessarily easy to do. So I'm going to show cases where I can emphasize sort of a search pattern and a checklist approach, but also show some cases that demonstrate really where some of the most common areas of pathology are that you're going to see day in and day out. So that if you can kind of master those, that takes care of a large percentage of the types of things you're going to be seeing.
Well, fantastic. I look forward to it. So I think that's a knee. We're going to start there, right? So we got a knee x-ray. Yeah. How do you approach your knee x-rays?
Well, in kids, the most important thing is it's almost always going to be growth plate injuries. So this is a pediatric knee. So when I look at this, the first thing I'm going to do is go across and look at the growth plates. Look for any areas of widening or asymmetry, and that's pretty basic stuff I think everybody is familiar with. And then you're going to look specifically at the metaphyseal corners. That's the area where you're going to have Salter type injuries, buccal fractures. Buccal fractures not only occur in the wrist, but they do occur in the knee, and they'll be in this metaphyseal zone. So you want to make sure that the cortex has this just very smooth curvilinear appearance, no buckling or indentation. And that the growth plates are smooth. But knee and urgent care, it's interesting because it's honestly really rare to find any kind of bone pathology on an urgent care view of the knee. You might see a joint effusion, and you might see some soft tissue swelling, or occasionally, you'll see a patellar fracture. That's almost always you're going to get the history that they fell on their knee. They landed on their knee in the front of their knee. So that history is going to be the clue most of the time. But really, the point of this case here is in a pediatric case, there's some bone pathology that's just unique to kids that you're not going to see in adults at all. And you won't see it very often, but on a pediatric case, it's kind of cool. And I thought it was a fun way to get the bone cases started.
Sure. So, back in residency when we were looking at long bone fractures, the tip that was given to me by a mentor was basically to put my finger on the cortex and just draw the cortex all the way around. So you go down the cortex and you go across the growth plate and you go up the cortex, and then you go around the epiphysis and you do the same thing and you trace your finger all the way around the cortex. As I'm, doing that in my mind's eye and I'm going through that, I'm looking at the femoral portion of it. All the cortex looks pretty unbroken. It looks pretty good all the way around, whether it's the metaphysis, the growth plate, or the epiphysis. As I get down to the tibia, as I trace the cortex going through the joint, I almost, my mind is looking at the two horns, the attachments of the cruciate ligaments as it goes down, and the one on, I guess, the lateral aspect it looks a little broken to me. It looks like there's a cortical disruption there, and so that doesn't look right to me. And as I follow around the rest of the joint, I don't see anything, and the remainder of the tibia, I don't see anything. I don't see anything in the fibular head. So that's how I would look at a knee X-ray. That's how I was taught to read it, and so you're going to ask me what that abnormality, how I describe that abnormality. I don't know. It's abnormal.
Just looks
It's an
wrong.
abnormal abnormality, and this is something that I would flag. If this was initially read as negative by my radiologist, I might say, look at this area right there, doesn't look right to me. What is that?
Right.
So I'm asking you as my radiologist, what is that? What am I missing here?
Yeah, that's a great pickup. I mean, just recognizing it is the important part, because it's actually a very specific pathology unique to kids, and it always has this same appearance. And as you described here, there's a regularity. This is the tibial spine, but this lucency right here, this almost horizontal lucency, that's really the avulsion fracture line.
So it's an avulsion. Okay.
Yeah, these tibial spines, this piece of bone is being pulled up, and in kids, the ligament, the anterior cruciate ligament, is actually stronger than the bone itself. So when you get a twisting injury, rather than rupturing your ACL, most often what you'll get instead is an avulsion of the tibial spines.
Wow.
And if you look on the lateral view, this is the same case. You can see here.
Just lift it right up. Sure.
Just lifts it right up. And here's that lucency that we saw in the frontal projection. So, kind of a neat case. It's certainly can be a lot more subtle than this, but pediatric knee, very few bone things are going to be wrong, but this is one of them to keep in mind.
Oh, that's a good tip, because I could very easily see that miss. That is a very subtle finding.
Yeah, and I'll just to point one other thing out that you'll see often on pediatric cases. A lot of times you'll get lucencies in this area or irregularities like you see here, and sometimes these are questioned as fractures or Salter injuries and so forth. But almost always anything you see in this area is going to be related to just a normal, tibial tuberosity. And in this projection here, you can see it right there. It's skeletally immature tibial tuberosity that can cause some really odd looking appearances.
Mm-hmm. Now, how would you differentiate that from somebody who has like an Osgood-Schlatter deformity of the knee?
Boy, that's a tough question. I can tell you in training, what we're taught, and I don't know how true this is, we're taught that that's mostly a clinical diagnosis, because we see so many variations here that are actually asymptomatic that, I guess it's fair if we see something really particularly prominent to describe it, and query, clinically. But we also see, the clinical diagnosis come in with Osgood-Schlatters, and we see a tibial tuberosity that looks almost normal. So I think it's really hard, radiographically to be sensitive or accurate with that diagnosis.
Okay.
Yeah.
The bane of any urgent care physician's existence is pediatric elbows. And I think I speak for all of my brethren in the industry that when you have a pediatric elbow injury, you're going to get an X-ray, but this is such a black box. So if you want to shed some insight in terms of your approach to that and to pediatric elbows and things that we're looking for, any tips you can give our colleagues and our listeners on pediatric elbows, we're more than ears.
Yeah, awesome, good. Well, this is really a tough area for us as well. And when I started doing urgent care 10 years ago with our group, even after being in private practice for so long, I didn't even feel that comfortable with these pediatric elbows. And I think as urgent care radiologists, we see more of these than any other, radiology specialty. We've gotten to learn a lot along the way. We could do maybe one time a whole podcast on pediatric elbow, because there's a lot of, variations and, growth plate irregularities, and the whole skeletal maturity of the elbow, as changes over time. So there's a lot of complexity to it. What what I wanted to focus on in this case really is, at least if you could start by knowing, what, the 2 or 3 most common pediatric elbow fractures are.
Mm-hmm.
And I'm talking either those 2 or 3 fractures, that's 99% of everything you'll see. So if you kind of know what those are and you focus your attention there, you don't need to know all the details about how these different, apophyses and epiphyses develop and so forth. But if you know how to recognize those fractures, you'll be in good shape. And this right here is what I think is the most common fracture that we see in urgent care. And maybe I think across the board, the most common fracture is probably a supracondylar fracture, but maybe more so in emergency rooms or some higher acuity trauma. But in urgent care, I think this particular fracture is number 1. So when you get an elbow, look at this area, and that's where the money's going to be. And if it's not jumping out at you yet, I can point it out here. And I'll give you a hint. It's not where this little black arrow is.
No.
That's
so the thing that struck me about this one, and this is my weak point. This is my Achilles heel, no pun intended. It looks like the ossification center on the other side of the elbow. It looks like it's a little widened to me, and that doesn't look right to me. So I'm gonna let you run with this and tell me where the abnormality is. But initially, I'm looking at all the growth plates, and the growth plates seem all right. But in that area, there's a little inflammation around that, and that ossification center looks the growth plate there for the ossification center is too wide.
Right. Okay. Well, that is one of the commoner areas for injury in the elbow. This would be the little leaguer's elbow or an avulsion of the medial epicondyle.
Mm-hmm. The medial epicondyle, yeah, that's it.
In this case, I would call it normal, but you have to keep in mind that often the X-ray can be normal, and you could have an epicondylitis, or you could have some injury to the apophysis here, and you could do an MRI, and this whole thing would light up, and there'd be edema, and there'd be some stress injury in here. So a lot of times clinically it is truly an injury, but we don't see it radiographically until this apophysis gets avulsed and really pulled off.
Okay.
And if that were the case, it would be a lot more obvious. There'd be some significant widening and asymmetry here, or even tilting of this bone. Sometimes they get pulled all the way into the joint space.
Mm-hmm, mm-hmm.
So this case, actually, the finding is right here. It's a very subtle sort of transverse lucency.
Sure. Yeah, now I see it, of course.
Yeah, through the lateral epicondyle. And this is, I think, the most common fracture site in urgent care, pediatric elbow. And it can be very subtle here. So my search pattern always starts with this area. This is the capitellum.
Yeah.
So in a much younger patient, the capitellum is not ossified yet. So all you're seeing really is the epicondyle, and you may just see a little bit of lucency there. So yeah, this is a good case. I think I have another. Do
you have a lateral view or anything?
I don't have a lateral. They're really, they're very hard to see in the lateral. The lateral will be typically negative, but I do have another example in a different patient of the same fracture. And that one is located.
I can see the subtle line. Yeah, there's a subtle line right there. The break in the cortex right there.
It doesn't look like much, but that's all. It'll be a little line here, a little line there. But anything right here, this is going to be where all the action is. The other thing, as we said before, supracondylar fracture, medial epicondyle, and olecranon. And we could talk a lot about elbow at another time, but just for starters, keep that one in mind.
Okay.
And then, kind of going in along the same theme with an adult elbow, there's a fracture that's, going to be the culprit, 95% of the time.
Yeah, we see this a lot. So, yeah. I mean, I can see the posterior fat pad and the sail side in the front. And I think there's I mean, you obviously, given the history, this is an adult, I'm looking for a radial head fracture. And I think I can see, subtle break in the cortex on the bottom portion of that radial head there. So awesome. That's what I'm seeing on this.
Good. Awesome. Yeah. You nailed it. It's radial head. That's the money in the adult elbows. Anytime you see the joint effusion like this, even the posterior more so than any lucency up here. Sometimes when the effusion is really large, you start to see this sail sign, but even a very, very small effusion will start to lift this posterior fat pad, which if you haven't seen a lot of these, it's this black, this lucent area here, just lifted up from the bone.
Mm-hmm.
Very sensitive for a joint effusion. And then just once you see that, just start, looking really closely. And any little thing you see in the radial head is probably going to be a fracture, as you said. And this is the same patient. This is the other view. And,
yeah, you can see it cracked right through the front. It almost looks like the top of a screw.
Exactly. That's exactly what it is. So this is actually radial head rather than your typical radial neck, which would be down here. The radial neck is more common, but you do get them in the radial head, and this is intra-articular going right through that joint. So cool case.
Mm-hmm. Yeah, it's a very, very common. We see it a lot. So.
All right. Keep it with the theme of common fractures. This was a 65-year-old patient who had a slip and fall the previous day and came in with swelling and pain in the wrist.
Mm-hmm.
And these, by the way, these are all recent cases that we see, and these are very common.
Sure. Well, I mean, common things being common, I'm worried about the distal radius, a fracture to the distal radius. So I think on the articular surface of that the distal radius, I see a break in the cortex there, and I would imagine that's where the fracture is.
Nice. Wow, Frank, you nailed it here. This is typically a really subtle fracture. It's one of the most difficult fractures to pick up, and particularly in elderly patients who have wrist injuries. If they're osteopenic, these can be really, really subtle. This
right
is
there.
The line right there. It's an intra-articular non-displaced fracture, and if you don't see it on this view, your other clue will be on the lateral view. When you're looking for these non-displaced, very subtle radial fractures, the other place you might pick it up is right here on the lateral view along the dorsal cortex of the distal radius.
Mm-hmm.
As you said before, you were taught to follow the cortex with your finger, and if you did that here along the radius, you'd get to this area where there's just a little irregularity. It doesn't look like much, but a normal wrist won't have that, and sometimes this is your only clue to a nearly occult distal radial fracture.
Mm-hmm.
So, just a tip there. Keep an eye on that area and looking at the articular surface, and hopefully, good way to avoid missing these difficult fractures.
What are other common fractures you see that are subtle? Do you see a lot of in the elderly? Do you see a lot of scaphoid fractures, or not as much because the bone cortex of the distal radius is not as dense as when you're younger?
Yeah, that's a great question. Almost all the scaphoids that we've seen are in young adults. It's not common at all to see them in elderly people, and I don't really know why. Maybe it's because of what you said. I'm not really sure, but in the older adults, it's almost always a radius. But one thing to keep in mind is there's a little bit of an anatomic variation here. This is a physeal scar. This is where the radial styloid fuses, and sometimes you get a pretty prominent bump along this cortex that can be mistaken for a fracture. So you want to keep that in mind. And as far as soft tissue goes, what you will see in older patients, more so than the scaphoid fracture, but this distance right here, this space between the scaphoid bone and the lunate is called the scapholunate interval, actually. And there's a ligament that holds these two bones together. And in wrist injuries, this ligament can get torn, and it allows this space to get widened. And this case is probably, it looks to be at about upper limits of normal, but if it gets wider than this, and I think the measurement is about 8 millimeters, then that's a sign for a scapholunate ligament injury, and that can cause wrist instability and some chronic pain. So That would be so-called Terry Thomas sign. And
Good to know. I'm glad we have you guys backing us up with your 8mm metric rulers. I like that.
I haven't measured one in a long time, but I like to eyeball it. All right, this is a layup for you, Frank. I'm trying to take it easy on you today.
Yeah.
This is not so much for, it's not supposed to be an eye test, but just, to make sure that all the listeners are aware of this diagnosis and its importance.
Yeah. So, I mean, the thing that jumps out at me on this one is the base of the second metatarsal. There seems to be a deformity down there, and I maybe even the cuboid underneath it. There's a fracture in there as well.
Yeah, that's the call here. So this represents a Lisfranc injury, which can be a very difficult diagnosis, and if these are missed, the patients typically have a really horrible outcome. So as you can imagine, there's a lot of medical legal liability around this diagnosis. The history is almost always some sort of crush injury. So that it's important to if you're sending an X-ray for interpretation, it's important to include that because as radiologists, that's kind of a buzzword for us, and we're going to look carefully at the Lisfranc joint. In this case, you do see the step off between the base of the second metatarsal and the cuneiform bone. This cortex here should line up with this cortex. So this is really a big step off here. So the ligament is torn, but what's important as well is this fleck of bone here that you described. This is a small avulsion fracture. So this is where the Lisfranc ligament attaches and a piece of bone gets avulsed off.
Right.
And most of the time, the dislocation part can be very, very subtle, but you will still see an avulsion fragment. And that may be your only clue to a Lisfranc injury. And we call that's called the flake sign. And it's very specific for a Lisfranc injury. And it's any little calcification or bone fragment in this first intermetatarsal space. Flake sign, very specific for Lisfranc injury.
No, I personally saw one of these in the clinic about 2 weeks ago. And the story was he had a 1,500-pound pallet jack roll over his foot with pain, in that area. And the X-ray finding wasn't nearly as pronounced as this one. Right. There was a subtle, a break at the base of the second metatarsal. There was a little bit of widening of that joint, but it wasn't particularly pronounced. And there was no other finding on the X-ray. It was just a really, suspect, cannot rule out, kind of a hedge. But, we had to set him up for, a stat orthopedic visit, which was difficult during the middle of the COVID epidemic. And we got an MRI, and sure enough, he had a Lisfranc injury. And so we didn't miss it. Just given the history, even if you don't see something, these people need really, really close follow-up. I would err on the side of caution because by disrupting the Lisfranc ligament, obviously you are completely disrupting the transverse arch, and the whole arch collapses, and this is a debilitating injury, and you have permanent disability for something that needs to be picked up and corrected in short order. Yep. So this is a great film.
Absolutely.
Thank you.
Sure thing. Okay. All right. Next up, we got a little ankle, which is probably my favorite.
Ouch.
My favorite joint here to look at. So kind of two teaching points here. One is the actual pathology, and the second would be kind of we can have a discussion together about how I like to approach an ankle.
Well, that neck of the calcaneus there, there's a little avulsion or some kind of crack up there. That's painful. What was the mechanism? How'd that happen?
This person fell down the stairs and so had some kind of twisting injury. I don't know, exactly if it was kind of a dorsiflexion twist or a straight inversion or eversion. I don't really know because they were kind of falling down the stairs. Mm-hmm. But that's certainly the finding here. This is a fracture through the anterior process of the calcaneus. And
so, I mean, there are various ways of your approach to looking at the calcaneus or looking at, an ankle film like this or a foot film. when you have somebody coming in with like forefoot pain or midfoot pain, and you know, you get these x-rays, there's a lot of bones that are densely packed in there, and you know, do you have a methodology? I mean, how do you go approach these, you know, to make sure that you're not missing anything subtle? I mean, this one jumped out at you, but if there's something more subtle, what are tips that you can give, you know, people in the front lines to approach films like this to make sure we're not missing anything?
Good question. Yeah, as you know, Frank, I'm a big, you know, search pattern checklist kind of guy. I think, you know, particularly in urgent care, you know, a lot of the pathology is the same over and over again. And you know, when you look at an ankle like this, I like to have several things that I run through in every film, and I feel like if I actively go and look for those things, I'm gonna get the diagnosis, you know, 99% of the time. And with an ankle, I include the anterior process, the calcaneus, in my search pattern, just because this can be very subtle, as you said, and I want to make sure I specifically look at it. So that'll be the first place I look. Next is going to be the base of the fifth metatarsal.
Mm-hmm.
Commonly, you know, they may not get a foot X-ray to go to this. This may be your only, you know, shot to really see this bone, and that could be the injury right there, a little avulsion on the fifth. The next place I look at is this the dorsal part of the talar neck and navicular bone. Right. It's common to see really small little avulsion fractures here. They just look like little flecks or flakes of bone, and they can be very symptomatic. So you want to make sure you specifically look there. The next place is the talar dome. Want to see just a very smooth, curvilinear, articular surface here, because you can have osteochondral lesions, which are, you know, little divots in the subchondral bone, and they're serious injuries, and this is the best place where you're able to detect those. And then lastly, looking back here at the posterior part of the ankle, sometimes you'll only see the fractures on this lateral view, and it could be an oblique fracture through the fibula that's non-displaced, and you don't see it on the AP or the oblique view. You'll only see it on the lateral view as a lucency through the fibula. Or sometimes it'll be just an isolated fracture of the posterior tibia or the posterior malleolus. Yeah. And that's going to be just a fracture line through this part of the distal tibia. And again, you won't see it on any other views. And these are not rare. We see a fair amount of these, and you've got to find them on the lateral view.
Actually, I've seen them from that history that you gave, falling down the stairs. You know, they have a calcaneus fracture, or, you know, some kind of, and they have an isolated posterior mal fracture. And it's something that, you know, it's unfortunately missed, and you have to look at it on this view.
Yeah, tough diagnosis. But you go through that checklist, and you kind of, you know, if you want to write it down somewhere, put it on a note card, you know, if you're not accustomed to going through that process, and just check those areas, you're gonna, that's where all the pathology lives. You know, a lot of people spend so much time, you know, trying to figure out the overlapping, you know, cuneiform shadows, and what's this little thing and what's that little thing. I mean, that's really hard to do. That's not really where the action's going to be. Let's see another ankle case here.
Speak of the devil.
Technique not quite as pretty. This was pain. This is a twisting injury. What do you think of this one?
Well, I'm concerned about that posterior malleolus. I think there's a break in the cortex there. That same person who taught me to put the finger on the cortex and go around, you know, yeah, taught me a little thing of, you know, the most commonly missed finding on any X-ray is the second finding. So whenever I find one, I always want to make sure that I'm not missing anything else. So if you hit the posterior malleolus that hard to fracture it, you know, I'm worried about something else being there. So when it comes to calcaneal fractures, again, it's one of my areas of weakness in terms of, like, you know, making sure the Bowman's angle is okay, or making sure it's not displaced in any way. I don't see anything on the calcaneus, but what am I missing here? Is there a second finding?
No, I wouldn't do that to you, Frank. Not yet. Not yet. But I like that. You know, the calcaneus, yeah, those are important fractures that you wouldn't want to miss. And I didn't include that really in my search pattern before, because I got to tell you, almost without a doubt, every single time, the history that we get is somebody somebody jumped from a height, either fell, not jumped, but fell from a ladder, fell from a roof, fell off of some significant height and landed on the foot, and they've got heel pain. Without that specific history, we don't really see any pathology here. And in this case, the calcaneus was fine. There is, if you go through the search pattern here, there is this rounded density here, which is, just wanted to point out as being a normal variant. You can get these accessory ossification centers, clearly distinguishable from an avulsion fracture just because it's very round and well corticated.
It's very well corticated.
Yeah, exactly. So it's not your typical avulsion. But the finding here in this case was, as you said, it's this posterior malleolar fracture. And, you can bet you don't see this on any other view. It's only right here. And that was a great pickup.
That's a great film. It's a great film not to have.
Yeah, right. All right, and this one. All
right, this isn't.
Yeah, any discussion of bone? You have one of these just more for the teaching discussion.
Well, this is one of those never miss films. You can't miss that, and if you suspect this clinically, even if you don't see an injury to the scaphoid, you really have to put them in a thumb spica film and set them for follow-up with hand and have a refeed film in within a week's time to make sure that there's no occult fracture here because of the recurrent vascularity of the bone. You're going to have a vascular necrosis. So this is obviously, this one you're not going to miss because you can see it. But any scaphoid fracture, you got to be very, very careful about.
Yeah. Well said. I totally agree. Some literature says that up to 30% of these fractures are going to be radiographically occult, like legitimately not visible radiographically, but
it's that high, huh?
Yeah, it's very high. So as you said, you have to be really vigilant about it. If the clinical findings are there, the follow-up is definitely warranted. But this is just a nice classical typical example of what this fracture more or less through the waist of the scaphoid will be. And believe it or not, those scaphoid views, those really help tremendously. So if you do have any suspicion at all of this injury, add those to your risk protocol, and that'll really not only help to highlight the film, but help, bring the radiologist's attention to that area.
Sure.
Okay, here, different patient, that's a same type of history. I forget the age on this patient, but they were playing softball and slid into second base and came up with wrist pain and swelling.
Yeah, I'm looking at that scaphoid bone. If you go in the cortex on the articular surface on the distal portion of it, I think there's a small break there. There's like a little chip, a little flake off the top of that, but that's the only abnormality I can see on that. But given the history, you would still treat it the same way.
Yeah, that's great. No, that is the finding here, and this is I'm trying to show you subtle ones. This is the finding. This is
that little flake.
More like it's an avulsion fracture of,
sure.
Of the scaphoid bone. Unlike the more commonly known transverse type fracture through the waist, this avulsion fracture off the distal pole, I feel, is even more commonly seen in urgent care. And
really?
I'm not sure why, if it's mechanism of injury or just less force required, but particularly in younger patients, we see quite a few of these, and sometimes they're just little small avulsion flecks. They don't carry the same risk of avascular necrosis.
No, because that's distal to the vascular insertion, correct?
Exactly. But they're they're symptomatic, and you need to make the diagnosis nonetheless, and
sure.
Something to be aware of as a common pathology.
But again, that's a great film because that's very subtle. That's very, very subtle.
And here is the same patient here. This is that scaphoid view where they're kind of laying out the bone, and really a beautiful look at it here.
And you
This
can
is the
see it
problem.
better.
Yeah, exactly.
That's fantastic. It's good technique too.
Yeah, yeah, nice bone detail there. And that I believe is our last one that we have for today, Frank.
Well, that was a really nice review of long bone injuries. I very much appreciated that. You know, I'm sure our viewers are appreciative as well. There are a number of really good tips that, you know, I'd like to incorporate in my practice, and I'm sure our viewers will as well. So
Cool.
I think we're going to have to collaborate again and come up with a couple more of these series, you know, and maybe we can do some body or some facial or something along those lines, because I think these have been very, very helpful. And I really appreciate your time joining us today.
Thank you. I would love to come back anytime. I have fun as well. Like I said, it's nice. I love to talk about x-rays, and not many people will sit there and do that with me for a long time like you do. So thank you for that. I do appreciate it.
My pleasure. My pleasure. I look forward to the next time. So until the next time, this is Dr. Frank Illuzzi signing off from the Master Clinicians podcast series. Thank you for joining us.
Thank you.